Okay, can I get us started, please? So now we're moving into session 2, where we're going to begin a focus on the 6 methods. We're going to start with a brief overview of the 6 improvement methods based on a meeting that some of us attended in November, and this will be presented by Dr. Rifat Atun. So Rifat is professor of global health systems at Harvard. He was previously head of the health management group at Imperial College and also served as a member of the executive management team of the Global Fund as director of strategy, performance, and evaluation. Rifat, are you there?
Yes, hi. Good morning to you.
Good morning. We can hear you. We can't see you, but we can hear you.
Yes, I think it's better I don't put the video because the bandwidth is not very good. I'm in South Africa. So my presentation has 3 components to it. I will briefly introduce the tools and processes in what we mean by these quality improvement frameworks, and then briefly summarize 6 quality improvement methods in which USAID have invested in over the last decade or so. And then I will identify a number of important considerations as a segue into the sessions that will follow mine. So perhaps I could start with the next slide. Yep. So when we talk about quality improvement methods, what emerged from our next slide, please, Rachel? Yeah. What emerged from the discussion that we had in Washington at IM was that these quality improvement methods actually have 2 very distinct components. The first component is what I call the hardware, i.e. the tools, what is being done. These refer to the interventions being used and the linkages among these interventions that form a package. But then there is a very important software component, which is how these interventions are designed and implemented in different contexts. So these are the processes, as was mentioned in the earlier presentation. And these processes relate to the approach used, the sequencing of the interventions, and the theory of change used. So when I present each of the 6 methods very briefly, please keep these 2 in mind, because I would like to come back to the what and the how, and some of the challenges that we face in relation to understanding what is being done and the measurement. The next slide, please. And next. So there are 6 quality improvement methods that USAID have invested in low and middle income countries. And I think it's very important to understand this distinction between the methods used in low and middle income countries and methods used in upper income countries, because there are a number of fairly well established methods elsewhere. These methods that consist of accreditation, clinical in-service training, POPI, the client-oriented provider efficient, improvement collaboratives, the standards-based management and recognition, and support to supervision. These account for 80% of USAID missions spend on quality of care. And the demand from countries will likely grow, given the focus on universal health coverage and the strengthening of health systems to achieve effective coverage. And the effectiveness component very much relies on improvement of not just access, but actually quality of services provided. So we need to really understand better the methods that have been invested in by USAID and their effectiveness, and in particular cost effectiveness. So let's have a look at these before we come to the issues. Next slide, please. The first method is a fairly ubiquitous approach called accreditation that has been used to accredit provider units, accredit education institutions, to accredit centers, to accredit a range of other entities. And typically these take the form of an external quality evaluation against a benchmark or set standard. And at the end of this process, there's a formal recognition that an institution meets certain standards. These may be minimum standards, these may be aspirational standards. And this is typically a voluntary process. So the institution that undergoes accreditation voluntarily opts in to be accredited. And the challenge with accreditation is that there are many components to it, as you can see in the figure. First of all, the standards of performance being measured vary. And what is being measured can relate to the infrastructure, to design of the institution, the way the institution operates, the decision-making processes, the way the data are used and applied, and the way the institutions are funded. And in fact, there are multiple accreditation approaches that look at either all of these elements, these tools together or in isolation. So there's a huge variability in the nature and the process of evaluation, ranging also from self-assessment to fairly lengthy inspections that could take 6 to 8 weeks. Next, please. The second quality improvement method, again, is fairly well established. And this approach has been, in low and middle income countries, has been widely used by JPEGA, by Johns Hopkins. And clinical in-service training is essentially a broad category of quality improvement strategies. But again, they use variety of tools and processes to train professionals who have already completed their formal training. So this is really continuing education and continuing development in service training. And it can be used to reinforce important information, for example, the guidelines that are currently in use, or introduce new ones, for example, new methods of managing a condition or a new process. Again, the challenge with this particular quality improvement method is that it's highly heterogeneous. Not only do the tools and processes vary, so do the duration of training, as well as the characteristics of the trainers and the trainees. And all of these together make it difficult to really assess and compare and contrast on the effects of this particular intervention. Next, please. The third is a method that's been really conceived by Engender Health called COPI, Client-Oriented, Provider Efficient. And in this approach, as you can see from the figure, there's a combination of tools and processes that follow a particular sequence, starting with an orientation, followed by a self-assessment. Third, a problem identification process and prioritization of these. Fourth, working backwards to identify the root causes of these problems, and then developing an action plan and having this agreed by the committee, and then developing an implementation plan to act on the actions that have been identified, and then completing the loop by reviewing the progress, and then going through the cycle again. So there's a progressive and recursive element to the implementation that seeks to achieve continuous improvement and continuous enhancement of the of the processes and the effects. Next, please. The fourth is the improvement collaboratives, which again combines a set of tools as well as processes. And this was conceived by Institute of Healthcare Improvement and has been now widely used by Universities Research Corporation. And in the improvement collaboratives, typically we have teams of providers and experts that work together and learn from each other. They identify a common goal or a set of goals and design approaches to achieve these. And these collaboratives are characterized by their inclusive nature, building a coalition, and typically run anything from 9 months to 24 months. And there's a structured process, as with COPI, to identify issues, set targets, implement actions, test the influence of the changes introduced as an approach to implement new interventions or more complex evidence-based programs. Next, please. The fifth approach is standards-based management, but recognition with it. So there is an incentive linked to the process. And again, this SMBR, as it is called as an acronym, is used by JPEGO. Again, the process follows similar to COPI. The issues are identified, the standards are set, then these are implemented in the institution, then progress is measured against the benchmarks or the standards set. But what follows is a recognition of the achievement and the reward that follows. And the reward could be economic or non-economic recognition. So this management method is used to improve performance of individual health workers, but also teams. And it emphasizes continuous improvement with the cycle that I've just described. The recognition is used as an incentive to maintain interest, to sustain motivation, and to ensure those who are performing well are recognized, which creates an incentive for those who are not perhaps doing as well. Next, please. Next is supportive supervision. And there are various versions of this. The supportive supervision that is financed by USAID has been rolled out by associates in many countries. Again, the process follows the earlier approaches that I've described. Here, the staff work together with a facilitator to set goals in order to correct the problems that have been collectively identified. And then the performance of the teams and individuals actually measured and performance assessed against the goal set. And the supervision can have various domains. This could be managerial, it could be clinical, or they could be educational. And typically the supportive supervision follows the so-called the PDSA cycle or an audit cycle. There's a planning phase, and there's a doing phase, then studying, and then acting. Quite similar to what I described earlier. Next, please. So what are the commonalities? What are the important considerations in relation to these methods? Next, please. Well, first of all, I think what's so striking about these 6 quality improvement methods is that they have 6 shared features. First is that there's a real emphasis to make the process multidisciplinary. The interventions tend to be experiential and on-site. Third, they all involve a self-assessment or some kind of benchmarking in order to identify problems, to set targets, or to identify goals. Fourth, then, a recursive implementation approach follows, combined in some cases with ongoing problem solving, either led by the team or facilitated by an external person. And the facilitation can vary in intensity. Again, facilitation happens in the methods that I've described, but this can vary in duration, in nature, in length, as well as who provides the facilitation. What's also very interesting in relation to feature is that the methods I've described tend to follow what I call single loop learning. So following Argyris and Schoen's single loop and double loop learning, they tend to follow a cycle, but without taking into account of the contextual and health system factors and other factors that might influence the successful implementation, rollout, or scale up of these interventions. Or even if the second loop is present, it tends to be fairly asymmetric. They may be considered, but not fully integrated into the approaches that tend to follow the single loop learning. And I think that's a very important consideration, given the emphasis on health systems strengthening that was mentioned earlier. Next. So in addition to the 6 important shared features, I've also identified 6 considerations that this committee should take into account. First, having reviewed the extensive set of publications that were presented to us before the meeting, I could not find hard evidence on the cost effectiveness of these interventions. There's some evidence, but not strong evidence. The second consideration, and we need to understand this in order to ensure that we are investing in evidence-based intervention. Secondly, we need to consider affordability. The context varies from country to country, and each of these interventions have a different intensity to them. The third consideration is feasibility. How feasible is the method in different contexts and different health system settings where resource availability may vary. Fourth, and critically important, is replicability. If we're going to have a population level impact beyond one particular center or set of centers, the approaches, the quality improvement methods described must be replicated in a seamless fashion. And linked to this is the 5th consideration, which is the scalability. Can we replicate, but also move to scale in a particular setting? And 6th is sustainability. Once these approaches have been introduced into a particular setting, can they be institutionalized? To the extent that they can be, once the external support and external facilitation tapers over time, can this institutionalization ensure sustainability? I think going forward in relation to decision making, these considerations are critically important. Cost effectiveness, demonstration of this, affordability, feasibility, replicability, scalability, and sustainability. Next. And my final slide, having established these important considerations and shared features, what are the implications for generating evidence going forward? So what characterizes these tools and processes is that there are multiple tools and multiple processes, and these are interacting over time. There's certainly a heterogeneity in the context or the heterogeneity in the context and health system factors and approaches used and the outcomes measured in relation to these improvement methods. So this makes both the generation and synthesis of evidence quite challenging, especially cross comparisons of methods themselves, but also for a particular method cross comparison in different settings. But that said, we need to understand what works, or we need to better understand what works, where, how, and at what cost. We also need to understand the contextual and health system factors that make these methods more impactful, feasible, and sustainable. And to be able to do this, and Jim began to refer to these earlier, we need to use mixed methods approaches. We need to understand what works, but how this works, or why a particular intervention or a particular improvement method works in different settings. So we need to use mixed methods evaluations and use quasi-experiments that are fit for context and also for purpose. I think given the complexity of these interventions and the processes, the traditional randomized controlled trials would be very difficult. Hence, approaches such as step wedge design or before and after studies that use approaches such as regression discontinuity and other approaches would be well suited in their assessment and evaluation. So thank you for your attention.
Thank you, Rifat. Questions? Let me also just clarify that questions can come from any place in the room, not just those around the table. Yes, Jishnu.
Thank you for a great talk. Just had one question because we heard it both from Ashish and from you, which is you say that in these contexts, randomized controlled trials will be very hard to do. And I'm trying to understand why, because outside health, the randomized controlled trials have now become very complex, and they could include randomizing districts into where the government is doing a bunch of different things in districts where they're not, or villages where Jeff Sachs is putting in a global push on development, and others where they're not. So I'm trying to understand, however complex the intervention, if you randomize, say, the hospitals into which the quality improvement process is going to take place, would that not be a randomized controlled trial? I'm just trying to understand that problem better.
Yeah. No, I think it's an excellent question and a very valid one. I mean, randomized controlled trials are typically, absolutely, they are the gold standard and very useful, but typically they're designed to test a particular intervention. So they're more reductionist in their design than the kind of interventions we're talking about. And I tried to highlight this early on in the presentation. We have a set of tools and a set of processes that are bundled together into what's called the quality improvement method. And in relation to this, what varies is the approach used, the facilitator, and the trainer. So what we're dealing with is a very complex intervention. Even if we're able to demonstrate an effect, say using a cluster randomized trial, it would be challenging to know what worked, what element of this complex bundle worked, and why. And what's the magnitude of the particular effect. One way of overcoming this might be to have really well-designed step wedge design, step wedge approaches, so that we can see maybe introduction of a particular element over time, so we can see the delta as an additional intervention is introduced. But looking at these particular methods, they are fairly well integrated bundles. You cannot do just step one and then introduce step two later. But it's not like a bundle of interventions, say IMCI, where one can introduce 4 of the interventions to start with, then add on another 2, then add on another 2. So I think there are design challenges. That said, that doesn't preclude this committee to think through carefully what methods might be appropriate that produce what I would call as good as RCT evidence. And I think that will be, I don't see this as a challenge. I see this as really a refreshing opportunity to build on some of the techniques that are currently available to us.
Okay, thank you, Rifat. We're sorry you're not with us, but appreciate your contribution.